CataractCoach.com, podcast series, episode number 120, with Dr. Prem Subramanian. What you absolutely must know about neuro-ophthalmology. Yeah, even for cataract surgeons like me. Welcome back to our Cataract Coach podcast. And today, I have a very special guest who's going to teach all of us, especially me, a whole lot. That is Dr. Prem Subramanian. Thank you, Prem, for joining us.
Thanks, Uday. It's a real honor to be here on the Cataract Coach. As someone who hasn't done a cataract in 18 years, but does all sorts of other surgery, it's a real joy to be here and learn from you and to do what I can to enlighten our listeners.
Yeah, we all learn together. And the beauty here is, so you're a neuro-ophthalmologist, a surgical neuro-ophthalmologist.
That's right.
Tell us your path in ophthalmology and how did you end up where you are today?
I never would have predicted this. And this is the cool thing, I think, about our careers, right? And so I started out doing an MD and a PhD at Baylor after my undergrad degree, and did my PhD in molecular genetics. During that PhD, I was sponsored by the NEI. My research had nothing to do with the eye, but they used to take us up to NEI once a year and show us ophthalmology research and things. And I'd already had a little bit of an interest in ophthalmology. So I ended up doing my ophthalmology residency. I had a military obligation, so I did that at Walter Reed in DC. And then during my residency, the Army said, well, we need a neuro-ophthalmologist. Our current neuro-ophthalmologist is transitioning out. And I said, cool, neuro-ophthalmology is interesting. I like the optic nerve. I like the kinds of diseases that we take care of. So I did that. But shortly before I went to my fellowship, an event called 9/11 happened, and I was on active duty at Walter Reed during that. And so we started taking care of a lot of soldiers and airmen and others who had been blown up in Afghanistan and then subsequently Iraq. And so I came back from my fellowship. So I went to Wilmer, did my fellowship there, came back and finished out my time on active duty. But during that time, I became much more involved in the surgical aspects of neuro-ophthalmology, orbital disease. There was a big part of that in my fellowship as well, but orbital trauma, strabismus, diplopia, traumatic brain injury, which remains a research interest of mine. And so then I carried these things out when I left the Army, went into civilian academic practice, and I've really made it a core. And I think it's a really interesting thing. If you look at some of the giants in neuro-ophthalmology, like my fellowship mentor, Neil Miller, he, before he retired, was a surgical neuro-ophthalmologist. Right. He did a lot of orbital surgery. He did skull base surgery. That's where I picked up my skull base surgery from, as well as strabismus surgeries. I don't think anyone would call Neil Miller something other than a neuro-ophthalmologist. So it's a really core part, I think, of the neuro-ophthalmology identity that somewhere along the way started getting shed. But some of the younger people coming into neuro-ophthalmology, I think, are being attracted in by the surgical aspect of it. And it's something we in NANOS are really trying to emphasize is an option for ophthalmology residents who think that neuro-ophthalmology is interesting, but say, I wanted ophthalmology to be a surgeon. Well, sure, you can be a surgeon. Maybe not a cataract surgeon, but you can be a surgeon and be a neuro-ophthalmologist as well.
Well, you did some really complicated cases then. So those traumatic injuries from the military, you're doing big orbital disease, you're doing a lot of fractures, traumas, you're doing ruptured globes, you're doing strabismus issue. I mean, you have like a very wide spectrum that you got to cover.
It is. And I think that's challenging and interesting and keeps us thinking. War advances medicine. And so we worked collaboratively. So it was my oculoplastics colleagues and I, and ENT and neurosurgery and facial plastic surgery, all working together to solve these problems of tissue loss, these problems of complex fractures. In fact, in the basement of Walter Reed next to the eye clinic was one of the first in-house 3D fabrication facilities for doing patient-specific customized implants, because we realized that we needed those to help to reconstruct the orbits and skulls of these guys who were injured in blasts.
Oh, that is so neat. So you basically get a CT scan of what the existing anatomy is, and you can 3D print basically any kind of like artificial support or whatever you need instead of just using something off the shelf.
That's right. And it wasn't even so much 3D printing at that time, because we're talking like 2003, 2004, but it was custom fabrication, right? So there was a lab there that would build these things, and then we would take them to the OR. And you still have to do this these days. You have to grind it down a little bit to get it to fit just right. But it was an amazing ability to have that right there in house and to get these things made and sterilized and ready for us to take to the operating room.
And now now you're a practicing physician, you're a professor with tenure at University of Colorado, and you still keep up that whole wide spectrum of your interests, right? Surgically, let's say.
I do. It's a really important part, I think, of what I do, and it's part of providing great patient care and teaching to the residents and fellows who are here.
No, it is for sure. But it's interesting how that kind of, like you were saying, at some point there's like a divergence. So a few neuro-ophthalmologists like you and Dr. Miller will keep doing things that are super surgical, as well as covering the full spectrum of neuro-ophthalmology. But then there are other neuro-ophthalmologists, kind of like my experience at UCLA when I was a resident, who were just, I never saw them in scrubs once.
Right. Yeah. And I can't really point to something specific that happened that led to that change. I don't know if it was just because certain people decided it was their interest, that they were not interested in surgery and they were going to concentrate more on clinical care. It may also be that certainly we're a specialty where many of us spend time in the lab or doing other, I spend time doing research, although I don't have my own lab. And I think it can be hard to do everything in that way, right? Like if I had a lab, I think I would have to really cut back on the surgical sorts of things that I do. It just wouldn't be possible to be good at everything.
Right. I mean, there are 168 hours in the week. You subtract about a little bit for sleeping, a little bit for eating or exercising, and having an actual social life or family life. And there are only so many hours you can devote to anything. So
that's right.
That makes sense. That is fantastic. I've heard you speak before at meetings. You're really a fantastic, very talented speaker. Because normally I would think that I would not be that interested in a neuro-ophthalmology lecture, to be honest. But you are super engaging.
Well, thanks. No, and that's something in neuro-ophthalmology, I think, that we try to emphasize, that because there's so few of us and we have many people who we want to reach out to and get information out to them. I want to do it in a way that, as I said, is engaging and that is going to stick in people's minds, right? Because when non-neuro-ophthalmologists come to neuro-ophthalmology teaching, what are they looking for? They're looking for things to avoid, right? Conditions to recognize so that they don't hurt their patients, so that they make crucial diagnoses. And if you stand up there and deliver that in a very dry way, no one's going to remember it.
Right.
And so I've been fortunate over the years to have role models of people who also know how to present information. I learned very early on in my career. I don't know if you've heard Peter Savino talk before, but he's a fantastic lecturer, fantastic teacher. And his slides are nearly devoid of words.
Correct.
Right? And it's just pictures. It's maybe a couple of words. And I think that to me, you really want people to be listening to what you're saying, not trying to figure out complex words on your slides, and then using those images to help sort of draw them in, right? We're ophthalmologists, we're visual learners generally, right? And so, if you teach people how to approach a situation, both in terms of listening to the patient and then looking at what's in front of them, they're going to retain it a lot better than putting up a bunch of words.
Oh, I think you're 100% right. In fact, when I give a lecture now, I give lectures a lot. I actually lectured in 21 countries last year, in 1 year. I don't do PowerPoint even.
Yeah.
If they say give a 15-minute talk about this topic, I'll put together a 15-minute video.
Yep.
And I will have the video play it's like a highlight reel. And often sped up. And for the exciting part, slow down, like literally watching a sports highlight reel for 15 minutes, and I will just talk over it live. So I want everyone to only look and observe the video.
Right.
And not have to read any words, like you said. Don't have to, just enjoy seeing this.
Yeah. No.
And then the nice part too with making an MPEG file, when they say give me a 15-minute talk, I make my video file like 14 minutes and 30 seconds, and I'm never over even a second.
Right. That's the key too, right? Your material's done, and there you are.
Right. But I think that's the best. We are super visual people, and I think that's really the way to learn here, for sure.
And, you're teaching obviously my residents use your videos, and they love the way the concepts are presented in that way. And I think that that's something that we as teachers need to make sure that we impart to our students, right? That they recognize that this is not just something we came up with. It is based on observing how people learn and based on what's important, and really just trying to present information in a way that's going to be retained.
Right. Now, you mentioned earlier, but you had a military commitment. I think that started when you were at Princeton for your undergrad.
It did. And yeah, I joined ROTC at Princeton. I would have never seen myself being in the military. I don't come from a military family. My parents are immigrants from India, right? And they never would have thought about the military. But I went to Princeton and I was like, wow, this is super expensive. And is there some way I can contribute to this, get it paid for? And I said, well, ROTC, I'll look at it. And I had no idea what it really involved. Sure. The head of ROTC was called the Professor of Military Science. He was a lieutenant colonel, military intelligence, had a master's in Chinese from Princeton, incredibly intellectual guy. Being this ignorant kid, I had this image of a military officer that was completely different.
Right.
And it opened my eyes to the idea that, wow, there's a lot to the military, and there may be a role for different kinds of people. And so I joined ROTC, got a scholarship, and then participated in that. Had a great time. I would not do it any other way. I was, sort of this introverted, nerdy, geeky kid.
We all are.
Yeah, right.
all ophthalmologists.
We are right. We just have a veneer on the outside that some of us that's a little bit more outgoing. But it forced me, right, to be a leader, to learn leadership skills, to learn how to be up in front of people and to motivate them to do something. And so that was a really transformative experience for me. And so that's where I got my military obligation. And then the Army had the good sense to put me on a deferral status when I went to do my MD and PhD. And then near the end of that training, they called me up and said, okay, you need to apply for a military residency. And if you match into the military, you're going to be going to one of the military facilities. And so that's how I ended up matching at Walter Reed.
Oh, that's fantastic. And then your MD PhD was probably part of the MSTP, the Medical Scientist Training.
It was.
Oh, it's fantastic then.
Yeah.
So you were smart enough to graduate with no debt.
I did. I was very strategic in that way. And, that's another thing that I think for anyone who's able to do it, it's a great thing, right? To come out at the other end. I mean, I feel so bad for our residents now coming out with hundreds of thousands of dollars in debt. I mean, it's crazy that it's like a mortgage that they have to pay back in 10 years after exiting residency. So you're right. It was a huge advantage.
But it's interesting too, how your experiences with the military then gave you such an incredible hands-on then with the complicated war trauma patients that 99% of ophthalmologists would never even see.
That's right. No, you're absolutely right. It was really, we were, as I said, creating things as we went along. And in this war, one of the big things we learned, and we've published on this, right, is that the use of body armor saved a lot of people who would have otherwise died. And so as a result of that, the number one injury in this war has been extremity injuries, limb injuries. Right. But number two is eyes.
Yeah.
Yeah, right. And so eye and head and facial trauma exactly has been huge. And so we really had to come up with better ways to take care of these people and then to help them afterwards, because of course a good number of them we weren't able to return them back to normal sight, normal function. And that's where the TBI interest came from, because there's just an incredible amount of injury from TBI that we didn't understand.
Traumatic brain injury.
Traumatic brain injury, exactly. And the concussive injuries from not even necessarily one big blast, but a lot of repetitive injuries from small blasts or concussions happening constantly during a deployment or in multiple deployments, right? Many of these soldiers ended up deploying more than once into theater. And they were experiencing these cognitive changes, these behavioral changes, and the sorts of things that sometimes can be misattributed to malingering. And these are not the kinds of people who malinger, right? These are the people who would say to me, Doc, how do I get better so I can go back into the field and be with my buddies and fight again? So they but they would have these symptoms that were vague. And it was really perplexing to us. And, I looked at them and I said, there has to be something here. And so we started realizing that there are a lot of ocular motor control problems that happen in people who have had repetitive traumatic brain injuries. And the ocular motor control system seems to be particularly vulnerable to this kind of stress and the integration with the vestibular and balance system. So some of the research we're doing now, this was DoD funded, and I'm doing it with a PhD vestibular therapist who's on our faculty here as well. We have an institute called the Marcus Institute for Brain Health. So Benny Marcus, who was one of the co-founders of Home Depot, he gave us $40 million to establish this Marcus Institute that is focused on studying injured veterans and elite athletes who have had multiple traumatic brain injury.
Sure.
And so Jeff Hebert, who's the PhD vestibular therapist, he's had a longstanding interest in the vestibular disorders that these people get. And because they're super high functioning generally, they try to overcompensate for deficits and they become almost hyper aroused. And this leads to some behavioral issues. This leads to startle responses. And then again, these kind of weird ocular motor things that if you don't know what you're looking for, if you don't pay attention to them, you might think the person's just making up symptoms. And so we're doing diffusion tensor imaging, DTI imaging of the brain as well, to look at disruption in white matter tracts in these people. And so we just submitted a paper for publication on the first part of this work, and we hope to have other things coming out on this. But I think it's going to change how we approach the care of people with traumatic brain injury, people who've had multiple concussions. It's become a huge industry. I'm sure you've seen this out there, that there are a number of doctors and others who have marketed themselves as TBI specialists. And some of them do have some training, but some of them don't. And they're offering a lot of interventions that, not surprisingly, cost a lot of money and are not necessarily covered by traditional insurance mechanisms. And they're aiming them at people who are hurting and want to be better. And we're trying to figure out which of these therapies is actually effective and which ones aren't, and which things get better with time. And people go and do these treatments, spend a lot of money to get better, but would they get better if they just did more conservative things and waited it out? So that's another area where we're trying to do more research, because we don't want our patients going out and spending money needlessly on things that are not to their benefit.
I mean, it makes a ton of sense. And I think it's interesting now we see traumatic brain injury kind of more often than we thought before. Now we see the people who I just, I do Brazilian jiu-jitsu, BJJ.
Yeah.
When I see your cauliflower ear, I think your brain probably looks the same as the cauliflower ear.
Yeah.
Right?
Yeah.
I mean,
no, you're right. We are also, our department, we are the ophthalmologists for the Avalanche and the Nuggets. And so for the Avalanche, we do preseason concussion screening because the NHL requires that now. It is amazing. Some of the, these guys are taking hits all the time, right? And some of the vestibular dysfunction and ocular motor control things that I see sometimes with some of these athletes, I'm surprised they can walk, let alone skate. They're such incredible athletes that they can compensate for these things, right? But their brain is taking these hits.
For our international listeners, we have a lot of international listeners too.
Yeah.
They're talking about the NHL, the National Hockey League in the U.S., and these are professional hockey players. And ice hockey, especially as I see it on TV or see it in person, it is a very violent thing. Yes. I mean, the joke is, I went to a fight and I saw a hockey game.
That's right. Exactly. Right. It's a high speed game, right? That's what it is. It's high speed, and you're running into people at high speed. American football, right? I mean, you have these big guys hitting each other, but they're only going about as fast as you can go in a couple of steps going off right from a standstill. But you put on ice skates and you're going, pretty darn fast, and then you slam into someone at the edge of an ice rink.
Yeah, so they're doing like 30 miles an hour or 50 kilometers an hour.
Right.
Ow! Right into someone.
Yeah.
No, it is no. I think we've underestimated this a lot. In fact, yeah, like I'm so crazy now. When I ride my mountain bike, I wear a full face helmet,
Yeah,
and all the young mountain bikers look at me like, "What are you doing, old man?"
yeah,
I'm like, "Yeah, but I know something you don't know, buddy."
that's right. Well, and then
And I'm wearing eye protector too.
yeah, well, when they show up in my clinic, because I live in Colorado, right? And so tons of mountain biking out here. It is not an infrequent thing
Yeah.
that the history is riding mountain bike, fell, hit face,
Yeah.
orbital fracture, or hit head, now has fourth nerve palsy and
And
diplopia from that.
let me ask you about that now, because I see that so much. I check every cataract patient very carefully for ocular alignment.
Yep.
I mean, more patients than I would have figured coming in with a head tilt who've had a fourth nerve palsy for years.
Yeah.
How common is this?
It is. You're right. When you look, you find it more commonly. I don't think we have good statistics on it,
Okay.
but I think that
What's your gut?
yeah. Was that
What's your gut instinct?
my gut instinct is that at least a few percent of people walking around out there have a fourth nerve palsy. I think it's probably a reasonably high incidence because it's so easy to injure the fourth cranial nerve, right? Minor trauma in childhood or even in adulthood. I once saw a guy, I mean, I didn't believe him at first, but he bonked his head getting out of an elevator and he got a fourth nerve palsy from that, or at least it was a decompensation of maybe a pre-existing fourth nerve palsy. And so, yeah, that's one of those things I think that more and more now we're recognizing it, right? So for example, maybe it's because people are living longer, maybe it's because people are just reporting it more, but this whole concept of age-related distance esotropia as well, right? Our patients who get double vision only at a distance, they tend to be older, they tend to have that, right, the deep superior sulcus and maybe a little bit of orbital fat atrophy, and we used to call them divergence insufficiency.
Okay.
Because we thought maybe it was neurological, right? That their brainstem center, we still don't know exactly where the divergence center is, but we thought that you would lose this divergence ability with age, or sometimes lose it in association with neurological disease. So these patients would get an MRI scan of their brain. Almost never did we find anything abnormal, right? And then Joe Deemer there at UCLA has done a lot of work on doing specialized orbital MRI, looking at the structures of the orbit and the relationship of the extraocular muscles to the orbital tissues. He's come up with this concept of orbital pulleys, which I think makes sense, where the extraocular muscles, as they come from the back of your orbit, they then interact with fascial elements at the orbital rim or along the orbital walls that redirect their force toward the eyeball. And with age, there are involutional changes that then lead to some slippage of these pulleys, and the mechanical integrity of the system is disrupted by that. And typically, again, it's a lack of function of the lateral rectus, so it's not pulling as much. And of course, then the medial predominates and you end up with this distance esotropia because you can't diverge mechanically. It's not a neurological problem. So we're seeing that, and we understand it better. And as a strabismus surgeon, we've become better at treating these patients because they have to be approached a little bit differently with how you do the surgery compared to kids with esotropia. You have to do a greater amount of surgery, recess the medial recti more than you would expect for a particular deviation. But that's something, again, we're seeing, I think, more and more, whether it's we're just getting better identifying it, or maybe it is that these patients are a little more or less accepting of just going to optometrist or comprehensive ophthalmologist and getting prism glasses. As we've gotten better and better with cataract surgery and making them spectacle independent, then they say, oh, well, why should I wear glasses to help my double vision, man, if I can do something else to correct that too?
No, it makes a ton of sense. In fact, if you're a cataract surgeon listening to this, and I'm sure there are a ton of them, out of the 18,000 ophthalmologists in America, 10,000 of them do cataracts. We're the lion's share. Next time you see a patient, I walk in the room, I look at a patient every time from the door. A lot of that head tilt. And that's okay. And you put them in the slit lamp, and they got a head tilt.
Right.
And I examine their eyes, and you know they have a head tilt when you examine one eye, and when you go to the other, you got to turn your knob on the slit lamp to go up or down for the other eye because they're not
right. Because it's not flat. Yeah.
Then I have them sit back and I say, you know what? Let me just do a quick 3-step test here.
Yeah.
And like, oh my God, you got a fourth in the palsy.
Right.
And it is, in my experience of cataract patients over the age of 60, it's like 1 or 2%.
Yeah.
There's way more than I thought it'd be 1 in 1,000.
No, I think you're right. I think it's an order of magnitude greater, like you said.
Right.
And you can obviously you're doing the patient a real service by picking that up, because I think that one of the things that sometimes results in these post-cataract patients being unhappy and ending up coming and seeing me is maybe it's because they can see better, maybe it's because they weren't aware of any sort of tendency to diplopia beforehand, but now they have diplopia after their cataract surgery. And there are a number of things that can cause that, decompensated phoria. I'm sure you do this, but I think that anyone who's thinking about doing any kind of monovision or multifocal lenses needs to look if the patient has some kind of phoria, because they may not adapt as well to that kind of refractive status. And so that's, I think, a really critical thing. And so, I think we're picking these things up more because we're looking for them.
Yeah, no, for sure. In fact, it's funny how you wouldn't think so, but sometimes the strabismus surgeon and the cataract surgeon need to work hand in hand together. I had a patient recently where Federico Velez at UCLA, fantastic strabismus surgeon, young guy. Actually, no, he's my age. He's not young anymore. Federico had this patient. He says, listen, she's had multiple strabismus surgeries. She's completely, I cannot make her ortho. He says, please do her cataract, make one eye plano, the other one -2 or 250.
Yeah.
She will be completely thrilled.
Right. No, that you're exactly right. Yeah, that is a strategy to. I have a couple of patients who actually have fourth order palsy, but one of them in particular has natural monovision, and he's about a -2.5 in his one eye, and so he doesn't care that he has this. He's just like, okay, I'm just going to go along. In fact, he has that naturally. He's older. His cataracts haven't gotten to the point where they need to be removed. But I think ultimately, when he does have cataract surgery, whoever does it should keep him in that refractive state so that he's still happy.
Don't put in multifocals and make him plano. He will hate you.
That's right.
Monofocal in, one eye plano, one eye -2.5. He'll be thrilled.
He will.
Now, Prem, I have an admission to make, a confession here. I made some notes.
Okay.
because I know you're going to be this podcast. And I'm like, you know what? I have so many questions I need to ask someone. And my local neuro-ophthalmology friends in LA would be annoyed if I bother with this.
Okay.
I'm going to ask for the benefit of everyone. Now, my first one is, I need to know, we tell patients, oh, you'll neuro-adapt to these trifocal or multifocal lenses. Are we lying to them?
No, I think that there is some evidence that they do. So it's really, I think, a bit rudimentary in terms of the studies that have been done so far.
Okay.
But there have been some pilot studies where people have tried to look with functional MRI to see if there is some kind of cortical reorganization or at least activity change that occurs in people who have multifocal lenses implanted. And I think there is a reality to it. I think it's not well mapped out.
Right.
But I think that we do know that there's neuroplasticity that extends well into our 70s and 80s. Okay. And, it maybe goes down a little bit, but it's still definitely there. I think one example is that I think, and we've all had patients like this. I had a patient who had longstanding amblyopia, and then her sound eye ended up getting severe herpetic disease, and she lost vision. She got to hand movements in that eye. Her amblyopic eye started to recover lines of vision, and she gained at least 5 lines of vision over a year.
So opposite the dogma. The dogma tells you what?
That's right. But because the brain had no other choice, she started recovering visual function in her amblyopic eye. And this has been described in the literature as well. And, it's variable in terms of how much recovery people get, but it's a well-known phenomenon. So I think that really speaks to this neuroplasticity that continues to exist throughout our lives.
So maybe our dogma is now dog food.
Yeah, I think that is one that would fit that category.
Because we were always taught, no, after the age of 10 years old, it's gone. That amblyopic eye will never get any more lines of acuity.
Right. No, and
there may not be set in stone.
Yeah, no, there have been some studies more recently that have suggested that, especially, like with teenagers now spending a lot of time doing video games and all this other stuff, that if you, even 15, 16, 17-year-olds, if you have them use their amblyopic eye
For
to
the video
do
games.
video games and things, that you can get some benefit.
Well, I mean, now that they're scrolling social media 18 hours a day,
Yeah.
it's like, I mean, that's a lot of visual stimulations.
Right. Absolutely.
Okay. Well, I guess also neuroadaptation is kind of like the people who live near the airport, they don't hear the planes.
Right.
But you go to their house and you're like, what's that noise? And they're like,
Like what?
not anything.
Yeah.
The brain learns to just, I guess it filters it out.
Yeah.
It just
Well,
doesn't-
our sensory system is constantly doing this, right? Like, do you feel your shirt that you're wearing? Not really. I mean, when you move, maybe you feel it a little bit, but you put on your clothes in the morning,
Right.
but you don't constantly feel them. You're not aware of them on your body. When you're wearing glasses, you wear them, you put them on, you feel them for a couple of seconds, but then that sensory system damps it. Otherwise, your brain would be overloaded. And in fact,
yeah, of course.
right? And so we think, so there's a condition now that's been described in neuro-ophthalmology or ophthalmology in general, visual snow syndrome, right? And have you heard of visual snow syndrome?
No, teach me, what is visual snow?
Okay, so visual snow syndrome is a condition where people experience, so you and I were old enough to know what TV snow is, right? Like TV used to go off
TV
the
snow.
air and there would be this staticky pixely thing that would be on the screen, right? And so people who have visual snow experience that pixelation of their vision that is typically superimposed on whatever it is they're seeing.
Oh.
They tend to notice it more on light monochromatic backgrounds, but they can notice it looking up at the sky, and they tend to have other exaggerated entoptic phenomena, like they'll see, the blood vessels of the retina, and they'll get more retinal after images than the average person. They may even have spots and things in their vision. And this is thought to be a hypersensitivity to visual stimuli, that there are portions in their brain that are not dampening the normal stimuli that the rest of us do in the way that the rest of us do. So, for example, our retina is pixels, right? And our brain fills in and smooths that image out so that our world doesn't look like, a screen. And their brain, for whatever reason, doesn't do it quite as well.
Oh.
And it is something that usually in retrospect, like people become aware of it often at a particular time in their life, but in retrospect, they'll say, yeah, it's like that. It's been like that my whole life. Maybe something triggers it to be worse. And it's been now estimated that 2 to 3% of the population may experience this.
Wow.
And it was really exacerbated during COVID when everyone did nothing but stare at screens, right? And so people started recognizing that they had this, because it's people who have it, it's super obvious when they look at video screens. And so neuro-ophthalmologists started getting a big influx of these patients. And the thing is, of course, neuro-ophthalmologists can't see 2 to 3% of the population. I mean, that would be insane, right? And so one of the things that I and others have been trying to do is to educate our patients about visual snow and to say, yeah, we recognize this is a real thing. It can be super annoying. It's not a disease, really. It's not going to harm your vision. It's not something that is progressively going to take away your vision or wipe out your vision and turn it into TV snow. And unfortunately, we don't really have treatment for it yet.
It's just that they're more observant of these things that make us everyone. They just notice.
That's right. That's right. And so I think that with that kind of approach, many of these patients, they get reassured that they don't have something crazy wrong with them. They recognize that it's just how their brain works. And many of them then, because anxiety makes it worse, if they are less anxious about it, then it helps to damp that down. So that's, I think it fits into that spectrum what we were talking about, that there's this sensory adaptation to our world in a lot of different ways. And people who have visual snow, their sensory adaptation is just a little bit different than other people.
Do these patients also recognize or see or notice their own blind spot?
Some of them do.
Wow.
Yeah.
So that's clearly that's like more brain than eyeball then.
Yeah, very much so. It's very much a processing thing. There's no miswiring. There's no retinal disease. There's no optic nerve disease
The eye
that
is normal. It's just
causes
when
this.
the signal goes to the brain, it gets a little bit
Yeah,
processed differently.
right. No, it's actually a fascinating thing. It's from a research standpoint, it's really intriguing. It's kind of frustrating clinically because we don't have any treatment to offer these patients,
Right.
and sometimes they get a little frustrated with us because we don't have a treatment. But it is a very interesting thing from a research perspective.
Well, you can tell them what I use. I use the special Jedi mind trick. So when I have patients come in and they say, "Oh, you did my surgery. I see this little arc shadow here, this negative disphotopsia."
Yeah.
I say, "Oh, you're very observant. Thank you for telling me." And then
Yeah.
you move on.
Yep. Yeah, that's right. No, and I think that's what you have to do. You have to just help them to recognize that, yeah, there are
It's
other things
okay.
we need to worry about.
Yeah, that it's okay. But I think, the brain eye connection there is so critical. Like for us cataract guys, refractive guys, that like I'm a low myope. I have myopia on the brain. So I'm, 50 plus.
Yeah.
I'm -2 spherical.
Yep.
But I only wear 175 because I don't want to wear the full corrections too much.
Yep.
And then I actually go around most times indoors with the snow glasses, and I don't mind that the distance is a little bit soft focus. In fact, I like it.
Yeah, right. It's what you're used to, right?
As long as this is really sharp. But then similarly, patients who are hyperopic their whole life, if you're a +4 hyperop and I do your IOL surgery and you end up +0.5, you'll think I'm a genius.
Yeah.
But if you end up -0.5, which is arguably better, you will hate me.
That's right.
So it's just like the brain connect. Or my other one is astigmatism. And God forbid you have a patient who is the toughest one of all. Plano -2 at 180. And this patient has 2 focal points, Plano and -2.
Yep.
They see at 50 centimeters and at 100 meters.
Right.
They don't wear glasses anyway. And they're used to that little bit of blur from the uncorrected astigmatism.
Right.
And you say, "Oh, I'm going to be a genius. I'll be a very good doctor. I'll
right.
make you dead on Plano with a toric lens, and you'll be Plano. And they hate you.
Yep.
So it's like so important to figure out what does the brain want, and deliver that.
Right. No, that's critical, and I think you're right. As we get more and more precise with the way we can do things, it becomes even more important to pay attention to those things. There's a correlate in strabismus surgery, right? That if someone has intermittent exotropia,
okay,
and you do surgery for their intermittent exotropia, if you make them esotropic, they are miserable because you have now made them constantly diplopic in a way that their brain has absolutely no mechanism to compensate for. Whereas with the intermittent exotropia, they would suppress when that one eye would go out. I mean, sure, people would look at them in a way they didn't like, but at least they weren't seeing double.
Right.
And so it's
what the brain wants.
Yeah, you have to keep the brain happy. So you aim for ultimately a slight undercorrection of those people so that they do not end up on that esotropic side. And that's the art of what we do, right? Is knowing how to do that, how to get patients. And sometimes you even have to make them a little esotropic shortly after surgery. And it's all in how you talk to the patients, right? If you tell them, this is going to happen. I'm doing this on purpose because I know you're going to be better in 4 weeks. And if I don't do this, you're not going to get the result you want. That's critical. And I think, I'm sure you and I both teach our trainees this, the art of telling patients what is going to be coming and what is going to happen down the road.
I mean, the classic example for refractive surgery is you do someone who's a little hyperopic LASIK, +2 hyperopic LASIK. Well, your ablation is probably +250, 275.
Mm-hmm.
So right after surgery, they're going to be -50. And you got to tell them, no, you got to wait a month or 2 before you're back to Plano.
Yep. Yeah.
That's what you have to actually. So no, it totally makes sense. Absolutely makes sense. But yeah, it's funny. I actually stopped teaching residents.
Okay. Oh, you did? Okay.
Yeah. I for 22 years, from 2000 to 2022, I taught residents for part of my week, oftentimes a lot of my week. But I actually retired from university professorship about 3 years ago. Now I'm a free man.
Okay.
Now, and in parallel, I've always had my private practice.
Right.
So now I just continue my private practice. And now, even better, we just teach the world through things like this podcast.
Oh, yeah, absolutely. No, I mean, the audience you're reaching with the videos and things that you do. I mean, it's amazing. It's really,
Yeah, it's fun stuff. Honestly, the best part is me learning.
yeah,
I'm selfish. I want to learn a lot. Now, I had some other questions. Now,
yeah.
neuro-ophthalmic complications of routine cataract surgery. And here's the ones I could think of. I
Yeah.
thought of, I'm only doing topical anesthesia.
Yeah.
But there are still good numbers of surgeons who do peribulbar, retrobulbar.
Right.
And I have seen damaged extraocular muscles causing diplopia afterwards. I've seen damage to the optic nerve.
Yep.
When I was attending residence, I saw 2 patients during my 20-year career where the retrobulbar injection went subarachnoid into the brainstem.
Yeah.
Oh my goodness.
Yeah.
So tell me about what are all these complications and how do we minimize all this?
Yeah. So you're absolutely right. So with a peribulbar or retrobulbar block, if you inadvertently inject into the extraocular muscles, you end up with short-term paralysis and then usually longer-term fibrosis. It tends to happen more with the use of bupivacaine in particular.
Oh,
in fact,
wow.
Yeah, because in fact, Alan Scott, before he passed away in 2023, he was studying using bupivacaine injections on purpose to treat certain strabismic deviations. By causing some changes in the extraocular muscle. So it's been pretty well studied in animals and in humans. And when we had the shortage of hyaluronidase was when there was a real spike in that, right?
Right.
Because then, once it got in there, it was in a pocket and it was trapped and it would just stay and cause scarring. So you're right, we're seeing less of that, but it remains a risk. And things that when I was still doing cataract surgery and we were transitioning from that to only topical, but when I had some patients who I wanted some deeper anesthesia or a subtenon's block avoids that, right? You cut down, you use a blunt cannula and you do that, and then you don't get into these problems. But, you're right. You do see that in the way we manage those patients is, once it's done, it's done. And once it stabilizes out, then they do reasonably well with strabismus surgery, usually one vertical rectus muscle, or if you need to do the contralateral eye as well, you can get the eyes aligned to give them a reasonable range of single binocular vision. So that is a complication that can be managed, but I think it can be avoided by just staying away from those injection techniques and using a blunt cannula instead if you really do need that deeper anesthesia for certain patients. And then as far as injection into the optic nerve, you're right, it can happen. I think it only happens with those longer needles. If you use a shorter needle, you're just not going to get deep enough to get into the optic nerve sheath. I will say that I saw one happen when I was still doing cataract surgery and I was staffing a resident. And fortunately, the anesthesiologists were right there. They put in a ET tube and ventilated the patient, and the patient did just fine because, of course, it's a short-term anesthetic, right? And they wake up from it, the anesthetic effect wears off, and they usually do just fine. But you're absolutely right. It's a scary complication when it happens. We don't want to see that. There are rare instances where people have injured the optic nerve with a retrobulbar injection like that. And that is unfortunately an irreversible complication when that happens. And again, fortunately, extremely rare. But once that injury happens, because it's typically a combination of a mechanical injury by physically injecting fluid into the nerve, but also an ischemic injury that happens from the alterations in the tissue perfusion when you start injecting into a closed space like that. So unfortunately, when that kind of injury occurs, it's pretty severe and not something that typically recovers.
And there's even a small incidence of ischemic optic neuropathies after just what you thought was a normal surgery and a normal retrobulbar or peribulbar injection, right?
There is, and we see it with any kind of anesthesia for cataract surgery, right? This topic is controversial, I will say, that whether or not there is a connection between NAION and routine, uncomplicated cataract surgery, because there were initial studies, probably not 25 years ago, that suggested that there was an increased risk for up to a year after cataract surgery for having NAION. Never made a whole lot of sense to me or some others, because what about cataract surgery would it be that would alter the ciliary blood flow to the optic nerve? It just in the short term, right? Intraoperatively or postoperatively, if you have big fluid shifts, big IOP fluctuations, then you might think that you could compromise that circulation to the optic nerve. And result in ischemia. But subsequent studies published over the years have come to differing conclusions as to whether there really is an association between, again, ischemic optic neuropathy and cataract surgery. I will say where it makes a little more sense to me and where we see it, I think, a little more commonly is with extended retinal surgeries, complex retinal surgeries, where, again, there's shifts intraocularly and the pressure can go up and down, and where there may be some compromise of optic nerve blood flow intraoperatively or immediately post-op. And I think that's one of the things that maybe has gone down with time as we're not patching patients and as we're doing the surgery in different ways, right? You don't have quite the same risk of a IOP spike after surgery.
Right, we're super cautious about that now, right? Yep. In the old days, I think IOP spikes were far more common after routine cataract surgery. Yep. Now I do things like what I call the angle sweep to make sure all viscoelastic's out of the angle, so that's not an issue. If I have any question about retained viscoelastic, I always give them a Diamox sequels in the recovery room, 500 milligrams, slow release Diamox or acetazolamide to keep the pressure low. And it's very rare now to see a post-op day one pressure spike. It's very rare.
No, and I think that's great, and I would expect, that would reduce the likelihood of getting some kind of ischemic event.
Yeah. Now, let me talk also about I got another patient that I got burned on. My mistake here again. I saw the patient pre-op, 20, 50 cataracts, 2, 3 plus nuclear sclerosis, pretty typical. Everything looked pretty normal. The only thing that was a little unusual was on the OCT scan. So my pre-op workup is I do a NIDEC OPD scan, which is like an autorefractor, pupil size, hydro aberrations, and topography. I do a Galilei tomographer. I do some sort of biometry like an IOMaster or LensStar or Alcon Argos device. And then on every patient, let me just have a baseline, OCT macula, OCT optic nerve. Before I do IOL surgery. Let me just see what I got here. And obviously a full, complete examination, of the retina periphery, the works. The patient looked pretty normal, everything. The only thing that was a little unusual was, on the OCT of the macula, and the retina came out thin. But okay, still looked normal shape, but it was just thin.
Yeah.
I do the surgery, and the patient does okay and just doesn't quite achieve great vision. Pre-op was 20/50, post-op like 20/40, maybe 20/30. And then I said, let me just put the patient on the visual field test.
Yep.
This patient's got like the textbook temporal hemianopsia and had a pituitary too. How did I miss this?
Yeah. So I get a few of these, more than a few every year, right? Where it comes in with exactly that story. And either the cataract surgeon then does the visual field after surgery, or they end up coming to me, right? I mean, at least you had the sense to do the visual field. Sometimes they come to me with kind of like, didn't get better after cataract surgery, and I do the field, and I find that. So I think the first thing to take away from that is never hesitate to do a visual field on someone preoperatively if you think there's a good reason to do it. Obviously, most patients don't need it, but I think it is rare that someone will regret getting a visual field test on a patient, because if it's normal, then great. And if you find something, well, then you have something to act on and maybe prevent exactly that kind of surprise that no one really wants. And so we tend to see it a little more commonly in patients with glaucoma, where maybe the field is not reviewed as carefully as it might be, and there's a temporal aspect of the visual field change that, of course, doesn't really go along with glaucoma. The other times we see this, though, and where I think it's important, it doesn't mean you're not going to do the cataract surgery, but where it's important to get preoperative visual fields are people, say, who have a demyelinating disease like MS. They may never have had an optic neuritis, but we know that over time, and especially now in the cataract population, right, they had their active MS at a time when the drugs weren't as good as they are now.
Right.
And so they may have had some subacute damage to their optic nerve, to the retinal nerve fiber layer, their macular ganglion cell complex, that if you don't pick that up ahead of time and you don't kind of set an expectation that, hey, you may not be that awesome 20/20, perfect vision after this cataract surgery. Some of your diminished vision may be from this chronic injury to your retina and optic nerve. The patient may be a little bit upset afterwards, knowing that. And I think that's important going into it. And especially if you're thinking about doing a multifocal IOL, I would not want to do it in that kind of circumstance, right? Because they already have decreased contrast sensitivity. And so there are also other situations where I know that people have picked up, or post-op, we've picked up that they probably had an NAION and they have an altitudinal visual field defect. Not again that the cataract surgery did it, or you wouldn't have done cataract surgery anyway, but knowing this beforehand is really important information.
Yeah. So in my situation here, so which patients would I screen with a visual field test? Anyone who has a thin retina?
So there are a couple of patients who you might do that. Anyone who has any hint of an optic nerve abnormality, definitely do a visual field.
Like meaning I look at OCT optic nerves, or I look at the OCT with a slit lamp and a 78 diopter, and it looks unusual.
Yeah, exactly. If any one of those things, right, OCT or your exam of the nerve you think is kind of funny, get a field. You know, it's easy, it's fast, and it may give you some important information. So those people should get a field. I think anyone who has a history of a demyelinating disease like MS should get a preoperative visual field. Anyone who's had multiple head injuries, probably good reason to get a preoperative visual field, because there may be just some things on there that go along with their visual concerns, right? So I think that there are a variety of patients like that who would benefit from having a preoperative visual field. And there's some people who've advocated for getting a pre-op visual field in anyone in whom you're planning to do a multifocal IOL. I don't know that I'd go that far, but I think that in anyone where there is any question, just like, I think your screening protocol for getting an OCT MAC, an OCT nerve, that's a great way of screening for the potential for some of these things being present.
It's funny, I laughed when you said about the trauma part, because I had a patient very recently where I'm doing the cataract surgery. One of my questionnaires of my intake, have you ever had any significant eye trauma?
Yeah.
And the guy clearly writes no.
Okay.
I do his cataract surgery. I'm going in there. I'm like, I start the rhexis and the capsule wrinkles. I'm like, bro, you got like the worst zonulopathy here. I got a CCR in. Your case it went fine, but it took a week off my life.
Yeah.
And then I asked the patient afterwards, I said, you wrote down you had no trauma ever. He's like, well, I did have that airbag hit me so hard that it broke my nose. I'm like,
right.
Thanks for telling me. Thank you.
Exactly, right. No trauma except.
I was like, man, your case took a week off my life, bro.
Yeah. Oh, yeah.
I hate surprises.
Yeah. Well, that's again, not that you didn't ask, but that is the essence of neuro-ophthalmology in some ways, right? Is digging and asking the question of the patient that no one else asked. Right. And that's sometimes how we come up with stuff. It's not like we're brilliant, it's just we ask questions.
No, you're right. For sure. But yeah, in this case, I tried. It was on my questionnaire.
Yeah, right.
I
wrote no.
The questionnaire says you wrote no prior trauma.
Right. Yeah, I can't do anything about that.
Yeah. Now, what's interesting? The more I go, the more years I've been practice now, doing tens of thousands of more cataract surgeries, I'm actually using the trifocals and multifocals a little bit less now than before.
Interesting.
And so one of the things that really swayed me is I have some trifocal patients who are like young, 38, got bilateral posterior subcapsular cataracts, bad cataracts.
Right.
Those patients are amazing. They love this. They think it's the best thing ever.
Yeah.
But then older patients, not as much luck there.
Yeah.
So a year ago, my dad died last year, but before he was alive, I didn't test. 85-year-old dad, 50-something-year-old me, 20-something-year-old son.
Yeah.
We get a flashlight, the same flashlight. Shine it in your eye for 10 seconds.
Yep.
Take it away. How fast do you recover vision to be able to read?
Yeah.
My dad, like 30 seconds at age 85. Me, like 8-10 seconds.
Yeah.
My son, 2 seconds.
Yeah, right. Yeah.
So clearly, are we asking too much of our visual system as we get older? Because the retina ages, the optic nerve ages, it doesn't function the same way.
Right. No, it's a great.
Asking too much.
It's a great point, and I think that we sometimes, right, we have these idealized models of how things work. And one of the things I see, and I think this is, again, talking about when you're approaching cataract surgery in someone with a history of an optic neuropathy. I see optic neuropathy patients who come in. I just recently had a man with LHON. He had the 14484 mutation, which is the one that people typically are more likely to get recovery of good central vision from. And he actually had. He had recovered pretty decent central acuity. But he's now in his late 60s. And he is noticing a progressive decline in his vision. It's not his cataracts, it's the natural attrition of retinal ganglion cells with age. But because he took a big hit to his RGC numbers when he had his LHON, he notices that age-related loss of the retinal ganglion cells, right? You or I, God willing, are not going to notice that as we age because we have reserves, but he doesn't. And so I think that's another thing when we listen to our patients who are describing some of these visual changes, it's important to know that history about whether they might have had an optic nerve injury or a retinal injury or a retinal disease, optic nerve disease in the past that is going to lower their reserves as they age.
Right. No, it makes a ton of sense, an absolute ton of sense.
Yeah.
Because unfortunately, the aging process means every body system, every organ is only on the decline. That's reality.
Yeah, that's right. The rate of decline might be a little bit different, but we're not gaining.
I saw a patient this last week who I hadn't seen her. Like I did her surgery like 20 years ago, and she found me. She needed a YAG capsulotomy, so she finds me. I see her, and she's like, "Doctor," she says, "What happened to you?" What do you mean? She's like, "You got a line right here in your forehead. You're a lot of your hair fell out. You got a lot of gray hair." I'm like, "Honey, let me do your YAG laser and hand you a mirror. I hate to give you the bad news. It happened to you too."
Right.
But I think with age, we got to stop promising patients youthful vision and instead be realistic, promise them better vision.
Right. No, I think that's a really good way to put it, right? I'm not going to make your eyes 20 years old again.
Right. No, that makes a ton of sense. Now, we talked earlier in the podcast, I'm going to kind of shift back to that, about NANOS, North American Neuro-Ophthalmology Society.
Yes.
That's a small group. How small is that group?
So it's small, but it's not. So we have at our meetings now over 1,000 people come to our annual meeting. Yeah.
Mind blown.
And a lot of them are trainees because right, neuro-ophthalmology, it's probably along with uveitis, maybe the most medical part of ophthalmology, right? Mm-hmm. We really deal with systemic diseases and things, and these trainees who, medical students or even young residents, they're still, they still remember medicine, right? And so they like that engagement. But we also get people who just want to learn neuro-ophthalmology who come to our meetings. So the society has about 650 members at this time. And we have become, although we're called the North American Neuro-Ophthalmology Society, we have a big international membership that's growing. Sure. Because we're pretty much the only focused neuro-ophthalmology society that has organized events like this and a structure and educational materials that are aimed at all levels. So everything from medical students all the way up to very senior neuro-ophthalmologists who want to increase their knowledge and keep up their skills. And so we have a lot of resources in that way. So our international membership is perhaps the faster growing component of the society. So we really, you're right. I mean, core North American membership is probably 500 people.
So of the 18, 19,000 ophthalmologists in the USA, how many are neuro-ophthalmologists?
Of the ophthalmologists, it's probably 300 or so.
Small number.
It is a small number, right? We've looked at, and there's a workforce shortage in neuro-ophthalmology, especially of ophthalmologists going into neuro-ophthalmology. So that's been a focus of NANOS, as I mentioned, is to encourage ophthalmology residents to consider neuro-ophthalmology and to let them explore whether it might fit into their career plans.
How many neuro-ophthalmology fellows do we graduate every year? Do you know some ballpark?
There are 35 neuro-ophthalmology fellowships in the country that have maybe high 40s total number of fellowships available. We don't fill. Their spots go empty. But but it's a small number of U.S. trained ophthalmologists. In this last year, I think there were 4 U.S. trained ophthalmologists who graduated from a neuro-ophthalmology fellowship, and there are probably about the slightly higher number of U.S. trained neurologists graduating from neuro-ophthalmology
Do you offer a
fellowships.
fellowship personally?
Yes, we do. Here we have a fellowship here at University of Colorado.
The one's got to be the best possible fellowship because you do all the
Oh, I
medical
think
stuff.
so.
Well, no, because you do the surgical stuff too.
Yeah. No. Oh, I mean, our fellowship, if I can put a plug for it, is fantastic. You said you have all sorts of people listening to this. We have 2 of my colleagues are neurologists, prominent, internationally known in their fields, one in neuroimmunology, the other in cognitive disorders that affect vision. And then, as you said, I'm a surgical neuro-ophthalmologist who provides a broad spectrum of care and surgical care. So yeah, a fellow who comes and trains with us is going to have an amazing experience.
I mean, you make me wish that I was like 30 years old again and a senior resident.
It's never too late.
The reason is, I mean, your fellowship will, I love the mentally stimulating kind of solve the puzzle part of neuro-ophthalmology. I think that's super attractive.
Mm-hmm.
What I never understood was like, how do you not do any surgery?
Yeah.
And you've got like best of both.
I think so.
Well, if you're a young if you're a senior resident, listen to this podcast. You can email Dr. Subramanian personally. This is something you should definitely look into. No, it's amazing because the spectrum of what you're offering is, I mean, they learn to do not just all neuro-ophthalmology, which we think is mostly medical, but they learn the strabismus surgery, orbital surgery, complex trauma stuff. The works.
Yep.
Wow. Plus, then you'll be able to answer Cataract Coach's questions with neuro-ophthalmology related to cataract surgery. So, wow. Well, Prem, listen, I can't believe it. We've been talking for an hour already. It's already been an hour.
Yeah. Oh, wow. Okay.
Time flies when you're having fun.
Indeed.
And I'm taking notes. So, again, I want to thank you so much. What an incredible podcast. Something very different for us, but I think something super useful. I'm going to promote the heck out of this because there's so much information in this podcast that I think every ophthalmologist, whether you're a neuro-ophthalmologist or cataract surgeon, wherever you are on the spectrum, you'll learn a lot from this podcast. I certainly did.
Well, I thank you for inviting me to do this. It was a real honor. It was a lot of fun, and I really hope the viewers and listeners out there are as pleased with it as you are.
Oh, fantastic. Yeah, it'll get about 1,000 video views and about 9,000 to 10,000 audio downloads. It'll be huge. And we're going to put down below in the description, you're going to have all the links. Dr. Subramanian will send me his links. I'll put them down there. And if you want to reach out to him, feel free to do so. And again, thank you so much.
Oh, thanks for having me.
And I'll remind our listeners and viewers, remember, we got a new Cataract Coach podcast every single week. Apple, Amazon, Spotify, Google. There's a reason it's the top podcast in all of ophthalmology. Plus, we now have a Renarounds podcast. You know who was on the Renarounds podcast recently? Your chairman, Dr. Madava.
All right.
Killer podcast. By the way, you can learn how they built University of Colorado from like a handful of ophthalmologists, like 50. It's an amazing,
incredible story.
Plus, remember, we got a new Cataract Coach video every single day, 2,600 videos in a row and counting. And now we have a new Renarounds video every single day too. So until next time, I'll catch you later.